Abdominal pain is one of the most overwhelming chief complaints because the differential is huge. But you don't need to memorize lists. Use a framework. Start with safety, then localize, then use key diagnostic forks. That's how you turn chaos into a diagnosis. If you can do this, abdominal pain goes from overwhelming to something you can narrow down quickly. In this video, I'll walk through a case of abdominal pain and show you how this framework makes your process so much easier. And later in the video, I'll show you the single decision fork that dramatically reduces your differential list. Before you walk into the exam room, you want to generate a broad differential, because that differential guides your focus history taking, your targeted physical exams, and then how you refine toward a working diagnosis. So let's apply that to today's patient, who's a 64-year-old male with abdominal pain. For lower left quadrant pain in the abdomen, you think colon first. Your top diagnoses could be diverticulitis, colitis, constipation or obstruction. It's also good to consider ischemic colitis, nephrolithiasis, and then if for a female body patient, gynecologic causes. So don't worry about memorizing this list. We're just using general categories, and then we're going to narrow those using patterns. Now is where we ask targeted questions. You want to clarify their abdominal pain. So you can ask about the location, if it's sharp or colicky. Next, we want to ask about the time course. How long has their pain been going on? If it's acute, you're probably thinking more diverticulitis or ischemia. Have they had recurrent episodes? That might be more indicative of malignancy or IBD. Next, we want to ask about pattern clues. Is there a fever? Then we're thinking infection or inflammation, still diverticulitis on our list. Is there a change in bowel habits? That could be malignancy or colitis. Is there diarrhea? That might be more infectious or inflammatory. If there's constipation, that could be an obstruction or diverticulitis. Next, we want to ask about key associations. Is there any hematochezia? If so, ischemic colitis or cancer could be on our differential. Are there any urinary symptoms? If so, that might be a renal factor. If there's postprandial pain, you might be thinking more ischemic colitis. Always be sure to check for red flags, like peritonitis, because that could be indicative of perforation. Make sure that their patient's hemodynamically stable, otherwise ischemia or sepsis is on your list. And if there's any GI bleeding, that's more urgent. So before you localize, make sure the patient's not crashing. Okay, let's apply this algorithm that I created for you to help with lower quadrant pain. First, check for red flags. Is there any kind of peritonitis? Are they hemodynamically unstable? Hematochezia? Any kind of severe pain that's out of proportion? If so, that's a ED referral for urgent evaluation. If not, then we move to localization. If they're having lower left quadrant pain, most common cause would be colon, but don't forget genital urinary or gynecologic causes. Next, our key step is pattern and localization. So is there any fever? If yes, that's indicative of diverticulitis. No, we want to ask if there's diarrhea or hematochezia. If there is, colitis could be at play with an infection or ischemic cause. If there's none of that, then we want to ask about pain being out of proportion. If that's the case, that could be ischemic colitis. If not, we want to next ask about constipation and distension, because that could be indicative of obstructive issues or diverticulitis. And then we also want to ask about flank pain or any genitourinary symptoms, because that could be caused by nephrolithiasis or pyelonephritis. Next, we want to ask about timing. If this has been going on for hours to days, it's likely more acute cause like diverticulitis or ischemic colitis. But if it's more of a subacute or chronic timeline, malignancy or IBD would be on our differentials. And if there's no clear pattern, then we want to revisit our differentials and consider things like atypical diverticulitis, early colitis, could be referred pain, or something extra abdominal. Your key takeaway here is fever and lower left quadrant pain is diverticulitis until proven otherwise. Once you localize the pain, you don't memorize lists, you start thinking in patterns. And within each location of the abdomen, you want to ask, is there an inflammatory pattern, obstructive? Is it vascular? Could it be referred? Or is it looking more like extra abdominal? Remember, location, pattern, and time are your key distinguishers for abdominal pain. Now that we've asked some focus history questions and used our algorithm, let's present our case. We have a 64-year-old male who presents with 2 days of progressively worsening lower left quadrant abdominal pain. The pain is constant and associated with fever and decreased appetite. He reports constipation over the past few days, but denies vomiting or urinary symptoms. Labs show mild leukocytosis, and he has not had a colonoscopy in 10 years. He also denies any recent travel or sick contacts. Since we've asked focused history questions, we can now perform targeted physical exams to help rule in or confirm our shortened differential list. In an OSCE exam, don't forget to check vitals and make general observations. So I've created a table here of some top differentials for our patient that we'd want to perform physicals for. So if there's diverticulitis, we definitely want to do an abdominal exam. And let's say for our patient today, we found some tenderness to palpation in the left lower quadrant with a little bit of guarding. Next, if we were wanting to investigate colitis, the abdominal exam is going to be clutch here, so don't forget to look and auscultate. And for our patient today, let's assume that the lower left quadrant had more diffuse tender pain, but there was no diarrhea reported. Next, if we were investigating ischemic colitis, again, abdominal exam is going to be important, but you could also do a fecal occult blood test and a digital rectal exam. So for our patient, let's assume there's no blood and the tenderness is proportional to the pain he's feeling. If we were suspecting nephrolithiasis, you could use a CVA tenderness test as well as the abdominal exam. So for our patient, let's assume there's no CVA tenderness. And then in a female body patient, be sure to check for any kind of ovarian symptoms. So if we were suspecting torsion, you'd need to do a bimanual pelvic exam. And this isn't applicable for our male body patient today. All right, now we can update our differential list and refine it a bit. So based on everything we've learned from our patient today, I think my working diagnosis is going to be diverticulitis. But to avoid premature closure, I'm going to make sure that I keep colitis and nephrolithiasis on my differential list. Colitis is less likely because the patient denies any diarrhea. And although there was no CVA tenderness, nephrolithiasis is still good to have on my shortened differential list. And while our patient today doesn't have any symptoms strongly indicating colorectal cancer, it is important to encourage him to undergo screening since he is overdue. Now we can bring everything together and present our assessment. We have a 64-year-old male who presents with acute, progressive left lower quadrant abdominal pain associated with fever and constipation. In-office exams today reveal focal lower left quadrant tenderness, the acute time course, localized lower left quadrant pain, and systemic symptoms are most consistent with acute diverticulitis. Alternative diagnoses such as colitis are less likely given absence of diarrhea, and nephrolithiasis is less likely without flank pain or hematuria. Given this presentation, further evaluation with CT abdomen is indicated. Now let's talk about where students go wrong so you can avoid these traps. First is missing diverticulitis. If you're just thinking about constipation, you're going to miss the clue of fever and lower left quadrant pain indicating diverticulitis, which is that until proven otherwise. Number 2 is ignoring age. This causes you to miss ischemia in older patients. So be sure in an older patient with pain out of proportion to consider ischemia until proven otherwise. And number 3 is skipping red flags. Before the diagnosis, be sure to ask if they're hemodynamically stable. Be sure to check vitals and then work on diagnoses. Okay, so don't forget our lower left quadrant pain approach is safety first. If the patient's not stable, then work to stabilize them. If there's peritonitis, that's a surgical referral. If there's blood or severe pain, think ischemia. Then you want to localize the pain. So in lower left quadrant, be thinking about the colon first. Then use pattern to help you narrow. So if there's fever, you'd suspect diverticulitis. If there's bloody diarrhea, that's more indicative of colitis. And if pain's out of proportion, then that's more indicative of ischemia. If there's constipation, be checking for an obstruction. Your final takeaway here is in right upper quadrant pain, time and triggers guide you, but in lower left quadrant pain, Pattern and danger signs help you decide. If you want to get faster at clinical reasoning, not just for abdominal pain, I break down the same framework across the entire ScrubNotes Chief Complaint Series. So be sure to check those out, and thanks for watching.